Hi guys, welcome to the Med Crash Course series. Today we've got our finals crash course on neurology and we're doing part 2 today. And it's being taught by Dr. Andrew. So in the bottom left corner you can see our email. If you have any questions later on, please do email us. And in the top right corner we've got our QR code for our Instagram page. So if you don't follow, please do follow. And we can go to the next slide.
Yeah.
So this is the QR code for our polls. So if you can just scan that in, and I'll post the link in the chat as well for people. There we go. If you can join that. And then I think we can just hand over to Andrew.
Okay, fantastic. So yes, thank you very much for that nice introduction. As Ashley said, I'm Andrew. I'm an FY2. Currently I'm in the emergency department, which is good fun. But today we're going through neurology questions. I've got a few nice ones and a few nasty ones, lovingly crafted by myself and colleagues, that is. And please do ask questions if you want to ask, either during the presentation or at the end, I don't mind. So let's start off with the first one, nice and easy, and I'll open the poll as well. So I'm just going to read out the question and give people time to answer. So first up, a 55-year-old woman undergoing treatment for breast cancer makes an appointment with her oncologist. Over the last few weeks, she has noticed some new troubling symptoms. She's been experiencing headaches that are worse in the morning. She's frequently been tripping over at home. You perform a cranial nerve examination. Examining her eyes, she complains of double vision. On looking to the left side, you notice nystagmus with a slow beat. Which cranial nerve is being tested? Now, I'm not sure if the poll is actually working. Let me just refresh the page and see if it is.
It's I don't think the poll's been opened.
Oh, yeah, it's stuck on a loading screen.
It's
there you
open
go.
now.
Now it's not.
Yeah.
I refreshed the page. That seemed to have worked. Okay, let's give people time. There we go. We've got responses. Fantastic. So let's stop that poll now. So that's right. The answer in this case is D. It's cranial nerve 6. That's, of course, the abducens nerve. It's a motor nerve that innervates the lateral rectus. Nice and easy. Now, this history is quite suspicious for something in particular, which I'm going to talk about. So we have someone with a known malignancy, breast cancer. These symptoms of headaches worse in the morning, which could allude to raised intracranial pressure. And then these signs, especially nystagmus with a slow beat, they all point towards some kind of cerebellar insult or maybe metastatic disease. So lateral gaze nystagmus that's sustained is non-specific, but in the case of someone with malignancy, we always have to think about metastasis. And this is the slide here, but if I'm ever asked about differentials lists and things like that, so I always use the surgical sieve, be it in OSCEs or interview stations or whatever. So probably the most common is alcoholic degeneration here, but then we've got our other causes like malignancy, stroke, multiple sclerosis, and the other neuroinflammatory disorders, drug-induced things. Of course, the best imaging, as it says here, is MRI, so MRI of the cerebellum, but that's a pretty specialist examination. So for final exams, that is, it's more important to recognize the signs of cerebellar disease. And in this case, we always use our lovely acronym, which is Danish, which I'm sure everyone has heard a million times before, with our dysdiadochokinesia and dysmetria for D. Dysdiadochokinesia obviously is not being able to perform rapid alternating movements, and dysmetria we test for with the pass pointing, as this slide says. We've got our A for ataxia with our broad base gait, N for nystagmus, I for our intention tremor, which is usually high amplitude and low frequency, S for our slurred staccato speech, just like me during Friday night, and hypotonia for H, which is decreased muscle tone, often very subtle on examination. But yes, let's move to our next one. I'm going to open the poll and let's read out the question. So a 64-year-old male was sitting and watching television one evening when he noticed he couldn't lift his left arm. When he stood up, it dropped to his side, and he described it as if it were dead. He became increasingly worried, called an ambulance, and was taken to hospital. On examination, he had no other motor signs apart from left arm weakness. Sensation was intact. It resolved after an hour of being in A&E. So where is the occlusion likely to be? And I'll give people time to answer. Okay, let's stop that poll there. Let's see what they've put. They've put A, which is anterior cerebral. Now, let me just see what's on the next slide here. Yeah, vascular territory. So the answer that I've got is lacunar from the polls. Now, this could be a lacunar stroke, I agree, just thinking about it. There isn't really a lacunar artery. Well, that's not really a term that's in vogue in neurology. We do talk about the branches that penetrate the deep brain structures coming from the middle cerebral artery, but I don't think they're usually called lacunar arteries per se. Maybe they're called lenticulostriatal arteries, if anything. But yes, lacunar artery can, or lacunar stroke or LACI can present like this. But I think given the terminology, perhaps the question maker here was looking for anterior cerebral. If we consider the vascular territory that is supplied by the anterior cerebral artery, mainly that superior part of the brain, and if we compare that with the motor homunculus, usually your anterior cerebral arteries do cause limb motor deficit or sensory deficit or both. I think other things that they tend to ask about in SBAs are behavior changes or apathy because of the involvement of the frontal lobe. With medial or middle cerebral artery, again, we can get the hemiparesis and sensory deficit on the contralateral side, of course. But because of the motor homunculus, we do get our facial symptoms here as well. And I guess in SBAs, they like to talk a lot about dysarthria and aphasia. For the posterior cerebral artery, exam questions love to talk about homonymous hemianopia, that's one. Also cerebellar dysfunction is another one. Things like your ataxia, your vertigo, your nausea and vomiting, and your dysarthria. And for the lacunar strokes, they're usually ascribed to particular stroke syndromes, of which there are classically 5. The ones that they tend to talk about are pure motor, pure sensory, the mixed motor sensory. One of the other ones that they sometimes like to examine people on is the clumsy hand syndrome dysarthria type. So let's just see what other slides we have. So the management of stroke in this case. The slide pretty much says it all. We've got TIA and stroke, of course. For TIA, again, we do give high dose aspirin and we refer to the TIA clinic. Further investigations are performed in the meantime, like MRI and carotid ultrasound. But with stroke, if we do suspect a stroke and it's very convincing, usually in your interviews or in your auscultations, it's best to say that you would contact the stroke team or transfer them to the hyperacute stroke unit. But the investigations that we would do as well are the CT head without contrast. And history taking is really important here because depending upon the time of onset, we offer them different things. So if it's within 4.5 hours of onset of symptoms, we can give them thrombolysis. I think they used to say within 6 hours thrombectomy, but now the guidelines have changed. If it's within 24 hours and there's convincing, let's say, occlusion because of a thrombus or embolus, then we can perform mechanical thrombectomy. It also mentions blood pressure here. Now, I think what they mean by this is that usually in an ischemic stroke, even if their blood pressure is high, we don't tend to control the blood pressure. Because if you hypoperfuse the brain even more by reducing the blood pressure, that could lead to further damage. However, I'd say the only instance where we might control the blood pressure is with thrombolysis. There is a bit of a threshold that blood pressure must be below, but it's still quite high. I think it's 180 systolic. And of course, for hemorrhagic strokes, we need the neurosurgical team involved for further management. And opposite to ischemic stroke, we'd stop anticoagulants and antiplatelets at that point. But it's all about the MDT and neurorehabilitation as well. Okay, so let's move on to the next one now. So, a 45-year-old man presents with headaches and visual changes. He has also noticed that his gloves don't fit as well, and his wife has commented that his jaw seems more prominent. You suspect acromegaly, secondary to a pituitary tumor. Which visual field defect would you expect in this patient? And we've already got responses, which is fantastic. Okay, let's just stop the poll here. So yeah, you're absolutely right. It's bitemporal hemianopia. This is again a really classic type of exam question. So pituitary tumors will press against the adjacent optic chiasm, which contains the decussating fibers which transmit information from the temporal fields of vision. There's this really nice picture here, which is a good overview of visual field defects. I would say the ones that they do like to talk about are the homonymous hemianopia, as we mentioned before, which could be due to lesions in the optic tract, the optic radiation, or potentially the occipital cortex. But if there is a lesion in the occipital cortex, it's usually macular sparing, as that picture in the bottom right shows us. And that's because the occipital pole has a dual blood supply, because this is the processing area for the macula, which is arguably the most important area of vision. Some exam questions like to ask about quadrantinopia. So always remember, if it's the parietal lobe, we'd expect an inferior quadrantinopia contralaterally. And if it's the temporal lobe being involved, we'd expect a superior quadrantinopia contralaterally. Okay, let's quickly move on from this one. Okay, so let me read out number 4. A 29-year-old male attends the neurology clinic with a 3-week history of worsening left-sided hearing loss. On examination, no abnormalities are detected on otoscopy, and Weber's test lateralizes to the right. You notice a brown patch on the patient's trunk, which he reports has been there since birth. An MRI head is requested, which reveals bilateral vestibular schwannomas, as well as multiple other intracranial tumors. What is the most likely diagnosis based on these findings? Okay, we've got answers already. This is going to be a very speedy presentation, I think. So let's move quickly on then. We have the answer being C, as suggested by the poll, neurofibromatosis type 2. Now, I've annotated this question. Of course, bilateral vestibular schwannoma is diagnostic for neurofibromatosis type 2. So in single best answer questions, if you see that, then always think about neurofibromatosis type 2 in your differentials. This MRI scan is actually quite nice. It does show bilateral vestibular schwannomas. Obviously, one is bigger than the other, but they have that classic ice cream cone shape, I believe it's called. And there's also some nodules there as well, which represent other intracranial tumors. And remember that neurofibromatosis type 2 is associated with tumor types like meningiomas and ependymomas as well. I'd say the brown patch on the patient's trunk is most likely this question's attempt at describing a cafe au lait macule. Now, you don't have to have cafe au lait macules to make a diagnosis of neurofibromatosis type 2, but cafe au lait macules do form part of the diagnostic criteria for neurofibromatosis type 1. So maybe it's a bit of a distractor. Sometimes SBAs also like to try and describe neurofibromas, which I guess they usually say there's lumps that are palpable under the skin, which are of course the tumors arising from the nerves themselves. So just to quickly go through some of the other options here, just for learning, neurofibromatosis type 1 is another autosomal dominant disorder, which is associated with tumors of the nervous system yet again. But we have cafe au lait spots as part of our diagnostic criteria, as well as the neurofibromas, and sometimes the exam questions like to talk about optic glioma, which causes blindness eventually, and also things like leash nodules, which are iris hamartomas, and axillary and groin freckling they sometimes mention as well. These patients might also have MSK abnormalities and learning difficulties too. And then this other option, Poitz-Jaeger's syndrome. This is another syndrome associated with cafe au lait macules, but mainly this syndrome is characterized by the development of hamartomas throughout the body. And overall, these patients have a higher risk of cancer. And then the final one here, tuberous sclerosis, another genetic condition. The name comes from the tubers, which are found within the cortex of the brain, as well as hamartomas, and the presence of all this tumor burden within the brain causes things like seizures, developmental delay, and behavior problems. It's also associated with skin changes though, and the ones to always look out for are ash leaf spots, which are depigmented patches of skin, supposedly in the shape of leaves, and shagreen patches, which are the thick, leathery, pigmented areas of skin. Okay, moving swiftly on. So number 5 out of 8, and I'll open the poll up here. A 20-year-old female presents with a 2-month history of altered sensation in her feet and a 1-week history of unsteady gait, requiring use of a walking stick. On examination of the lower limbs, proprioception and vibration sensation were absent, and power in the lower limbs was 4 out of 5 bilaterally, with hyperreflexia. Upper limb and cranial nerve examinations were normal. Romberg sign was positive. Blood tests showed no evidence of infection nor autoimmune disease. When her mother has left the room, the patient admits to abusing nitrous oxide. What is the most likely investigation finding based on these results? Okay, so we have some answers already. Let's stop the poll here. Now, I thought this was a very difficult question, but you answered very quickly, which is quite impressive. The answer is, of course, C. You're absolutely right. Low vitamin B12 levels. And the underlying diagnosis here is subacute combined degeneration of the cord. Now, this is a bit of a hot topic in neurology, actually. The fact that nitrous oxide, which is becoming more and more prevalent in its use and abuse, can actually cause subacute combined degeneration through low vitamin B12 levels. But in SBAs, the classic presentation is someone who has started taking folic acid and they didn't know they had a vitamin B12 deficiency. And I guess it unmasks or reveals a vitamin B12 deficiency that they didn't know about before. But this is another common presentation that you most likely will see in real life. And it is with these young people who become incredibly unsteady as well. So I've annotated this question here. The first part shows that proprioception and vibration sensation were absent, demonstrating that the dorsal column has been affected here. The second part shows that there's hyperreflexia, that's a UMN or an upper motor neuron sign, suggesting that the lateral column is involved. And the third part here, Romberg's sign was positive. This is a sign of spinocerebellar tract involvement. And of course, it's the combination of dorsal and lateral column degeneration that gives this disease its name. So, yes, I've put this picture of a transected spinal cord just to remind everyone. Right at the back, we have the dorsal column, which controls proprioception and vibration. Don't know if you can see my mouse, but that red triangle or pyramid shape, that's the lateral column, which is the corticospinal tract. And then we have right next to it the spinocerebellar tract, and that pretty much forms the lateral column. So the dorsal and lateral column involvement causes your UMN signs, your loss of proprioception and vibration, and some ataxia too. Just quickly going back and looking at the other options. So CSF lymphocytosis is of course referring to some kind of infection within the intracranial space, things like meningitis or encephalitis. Space occupying lesion, this history is not very suggestive of it. The HbA1c of 100 is trying to imply poor diabetic control causing peripheral neuropathy, but again, this isn't peripheral neuropathy. And unmatched oligoclonal bands make you think about multiple sclerosis. So let's move on to number 6. I'm going to open up this poll. So a 69-year-old male attends the neurology clinic with symptoms of slowed movement, bilateral tremor, and muscular rigidity, which were unresponsive to levodopa therapy. The patient's daughter explained that her father had balance issues, leading to multiple falls, where he seems to fall backwards. He was becoming more irritable and apathetic, not wanting to leave the house. On examination, you note that the patient has difficulty following eye movements, especially vertical movement and blinking. What is the most likely diagnosis based on the clinical history? Okay, very good. We've got some responses and I'll stop the poll there. Again, I'm very impressed answering these questions quite quickly and accurately. So as the poll suggests, of course, the correct answer is B, which is progressive supranuclear palsy. Now, all of these options have acronyms next to them, which is quite nice. But this is all about differentiating between different syndromes that have Parkinsonism within them. Now, features that point towards progressive supranuclear palsy are the fact that we have atypical Parkinsonism, which has a bilateral tremor and doesn't respond to levodopa very well. we've got this statement about falling backwards, which is actually quite typical for PSP. And finally, this difficulty with eye movements and vertical movement, again, is quite characteristic of PSP. So this is a slide that I made many years ago. Essentially, it's saying that Parkinsonism, just so we remember, is the bradykinesia, the rigidity, the resting tremor, the postural instability. And classically, or true Parkinsonism, where you have your asymmetrical resting tremor that responds to levodopa therapy, is most likely caused by idiopathic Parkinson's disease. But sometimes Parkinsonism can be associated with the Parkinson's plus syndromes. So we have here corticobasal degeneration in the top left. I don't think it's asked a lot about in SBAs these days, but I'll go through it just briefly. The way I always like to think about it is we have cortico and basal. So cortico is the cortex. If there's degeneration here, we get cognitive problems, or problems with behavior, language, empathy. And then we have basal, so basal ganglia degeneration, and that causes problems with motor control. For example, the alien limb phenomenon, which is usually how they talk about it in exam questions. We have PSP, which I won't cover again. We have multiple systems atrophy, or MSA, in the top right. The exam questions love to talk about the prominent autonomic nervous system involvement in MSA, and that can be your bladder or your bowel control, postural hypotension. But then you have your other systems alongside your autonomic nervous system, causing things like ataxia, problems with speech. And then finally we have dementia with Lewy bodies, or DLB. Now DLB starts off as dementia with this chronic progressive decline in cognitive function. But then there's a later onset of Parkinsonian features. And also in single best answer questions, they love to talk about visual hallucinations, usually animals or people, is what the science says. Okay, so let's move on to the next one, number 7. So a 34-year-old female attends her GP with fatigue. She describes feeling excessively tired after exercise or when exposed to heat, and has a stumbling gait, resulting in a fall at home. She also reports intermittent episodes of reduced visual acuity and pain around the right eye, which she attributes to her tiredness. Apart from an episode of a trapped nerve several years ago, there is no past medical history of note. Based on the clinical history, what diagnosis must be ruled out? Okay, fantastic. Let's stop that poll there. And we have, of course, the correct answer, which is C. Very well done once again for these ones, which are getting a bit more difficult at the end. I've annotated this question again, as I like to do in the real exams. We have a young lady who's excessively tired after exercise or when exposed to heat, which is Uthoff's phenomenon, or at least what they're trying to describe. There's reduced visual acuity and pain around the eye, which is most likely trying to describe optic neuritis. And then finally, we have this history of maybe trapped nerve. It's in inverted commas after all. So it could be another potential demyelination episode in the past. So all of these things make us suspicious of multiple sclerosis as a diagnosis. Of course, we can't officially diagnose someone with multiple sclerosis based on this history. We need to look at the McDonald criteria. Now, I think, So there's this big table, which is the McDonald Criteria, which you definitely do not need to memorize. What the main principles are: dissemination in space and dissemination in time. So for dissemination in space, usually we take an MRI, as this lovely image shows, where there's multiple lesions at different places in the central nervous system, so in the brain or the spinal cord. And then for dissemination in time, we can also use an MRI. So some lesions might look older than others, especially if we do specialist scans like contrast MRI or gadolinium contrast MRI. But the history can also show us dissemination in time, so a second attack. Sometimes the single best answer questions like to mention oligoclonal bands. And this is just really another way of showing dissemination in time. The oligoclonal bands are always unmatched in multiple sclerosis, which shows local immune activity. Now, of course, multiple sclerosis in the majority of cases is relapsing and remitting. So we have this history of relapsing and remitting neurological symptoms, which could include things like weakness, paresthesia, spasticity. And gradually over time, it causes disability. There's other disease causes as well, although very unlikely to be examined upon because they're quite niche. We have this very brief slide, which I concocted, showing the management of multiple sclerosis. So if you're asked to answer this type of question in an interview or in an OSCE, which is quite mean, the main way I would structure it would be to manage the patient's symptoms, which is supportive therapy, number one. For example, if they have spasticity, which is really painful, you can give them medications to try and resolve it, like baclofen or physiotherapy. If they have a lot of neuropathic pain, we can give them neuropathic painkillers. Or if they're having problems with the bowels or bladder, we can give them medications or catheterize to sort that out too. We can manage relapses. Again, usually if someone has a relapse, we give steroid therapy as a first line. And there's also PLEX, which is the very fancy way of saying plasma exchange or plasmapheresis. And finally, we have disease-modifying therapy. The one that they talk the most about is interferon beta, but there's lots of other fancy ones which we won't go into too much, and monoclonal antibodies besides, and then other medications like fingolimod. Okay, and finally, let's have our last question, which is number 8. We're making very good time here. So a 45-year-old gentleman attended his GP, reporting muscle weakness, lack of coordination and fatigue. He first noticed this as he kept tripping up over his feet whilst on his daily jog. He's otherwise fit and well, with no past medical history of note, and he does not take regular medications. You decide to perform a neurological examination on the patient, the results of which are the following. I won't read out all of that because it's a lot, but what is the most likely diagnosis based on the patient's history and clinical findings? And I'll give everyone some time to answer. Okay, very good. Let's stop that poll there. And once again, you're absolutely right. It's B, motor neuron disease. Now, they like to ask this question in exams because there's always a way of identifying it. Usually in SBAs, they'll give you a mix of upper motor neuron and lower motor neuron signs. And when they do that, always think about motor neuron disease. In this case, we've got our positive Babinski reflex, which is an upper motor neuron sign. It's hyperreflexia, essentially. And then we've got tongue fasciculations on the left side, which is a lower motor neuron sign. tongue fasciculations and the use of the word fasciculation in general in SBAs, always think about motor neuron disease as well. Okay, so motor neuron disease, just as a short word about it, is of course a relentless, progressive degeneration of all of the motor neurons. That's the upper motor neurons and the lower motor neurons. And so you get UMN and LMN signs. It results in asymmetrical neurological symptoms at multiple levels, which eventually progresses to facial and bulbar muscle involvement, where the individual have problems with chewing, speaking, and swallowing, and then eventually the respiratory muscles, which will cause death. Sometimes SBAs will ask about what studies we should do to diagnose motor neuron disease. It's actually mainly based on the history, but electromyography and nerve conduction studies are used to aid in the diagnosis. And as for the management of motor neuron disease, it's mainly supportive, once again, with the MDT being involved, with an emphasis on symptom control, kind of like with multiple sclerosis again, giving baclofen if there's painful spasticity and things like that. There's one medication which is licensed to extend survival time in individuals with motor neuron disease, and that medication is called riluzole. It only improves survival time for a few months though, and just kind of delays the time before someone needs ventilation. And the only other life-extending treatment, as I just mentioned, is ventilation. Okay, so on that rather depressing note, I guess, that's the end of the questions. That's all 8. Thank you very much for participating, and I must say, very well done on your answers to these questions. Just keep it up for the exams. So I have my last slide here, which has a nice QR code for feedback, please. It would really be appreciated. Oh my goodness, it's very late. So we can improve for next time. And if you do have any questions, please do ask. I can't see the chat, but I'm sure someone will tell me if someone posts in the chat, or just unmute yourself and ask. I'm very willing to answer.
Yeah, there's no questions in the chat.
Fantastic. Yeah, I'd say we made very good time today.
We did. Thanks again, Andrew, for doing the session. And again, please
Thank you.
do fill in the feedback form. It's really useful to get your feedback, and it helps us improve for next time as well. And the presentation will be uploaded on YouTube as well.
Thanks so much.